Manly and here, but in it, no?
Okay, was I?
Okay, was I the minute summer was it?
A hobby. It's your meal, amigo.
Let me about it. Me about it.
Oh, me and my say.
Yeah. A hobby, yes, eh? Can you do goals anyway? Jang, a room, a 2 hours, no? Yeah, actually, Samoy. You know, Manly and Nelly.
Okay.
And he told me, you know, see a nail goal, you know, in Colime, no?
Okay, put them here.
No? Beans.
Okay.
Yes, we call. Say nail to Colime, no? Okay.
Oh, them out there.
Chip out to salad, no? Generals, Bejadiam, Nanai. Chia Bejadia, Lieutenant Tony.
Oh, tell you what. No, Tony, but a mother, I know, something I listen.
You think on the sum.
Nana is an artist who tonight always run and I go to you.
Want to do that, but.
Hope I segment.
Yeah, the salad of a general sack for them, no?
Okay, was segment.
Yeah, no? Sorry, no?
Okay, was segment.
Good afternoon, ladies and gentlemen. It's my great pleasure to honor this section on the pre-paper regarding the surgery. And first of all, I would like to start with the first speaker, who is Hani Tung from Manly General Hospital. So without further ado, I would like to invite Hani Tung for your presentation, please.
Good afternoon, honor professors, associate professor, and all the special guests invited. I'm Hani Tung, and from University of Medicine, Mandalay. Today, I would like to present my paper presentation. The title is The Colorectal Score for Predicting Risks of Anastomotic Leakage in Colorectal Surgery. Introduction. Surgical resection is the mainstay of curative treatment for the primary colorectal malignancies and some inflammatory bowel diseases. The usual procedures of colorectal surgery involved the resection of a diseased portion and anastomosis of currents of the intestines. Anastomotic leakage after colorectal surgery is a major and potential life-threatening complication. It increases post-operative morbidity, surgical mortality, duration of hospital stay, and has also been associated with a higher local recurrence rate of colorectal malignancies. Anastomotic leakage typically becomes clinically apparent between the 5th and 8th post-operative day. After leakage has been encountered, consequences are severe. If anastomotic leakage is detected earlier before the obvious clinical signs and symptoms, prompt and early adapted management can alter the prognosis of the patient. Clinical deterioration in early stage of anastomotic leakage is difficult to recognize. Therefore, prevention remains the best approach. Early diagnosis and effective management is also vital to prevent consequences of anastomotic leakage. Several clinical scoring systems, such as Modified Early Warning Score, JUICE score, have been published in detecting risks of anastomotic leakage, and also the others, acute phase proteins, such as procalcitonin and C-reactive protein, are also used to detect anastomotic leakage. Since they are non-specific inflammatory mediators, other infective conditions also cause a rise in their levels. So, diagnosis of anastomotic leakage is usually delayed and the appearance of clinically obvious symptoms. Therefore, it needs to combine with clinical assessment to generate an accurate identification of advanced events earlier. Although many studies have focused on preoperative factors, such as age, sex, neoadjuvant therapy, and post-operative factors, such as non-specific inflammatory markers, the intraoperative factors were not usually included. In this study, it includes both pre- and intraoperative risk factors. Therefore, CLS score is more reliable in detecting risk on anastomotic leakage for particular patients. It is based on 11 parameters. Their age, sex, ASA scoring, BMI, intoxication, neoadjuvant therapy, elective or emergency, distance or anastomosis to innervation, additional procedures, blood loss or transfusion during operation, and duration of the operation. Age is expressed in year, less than 60, 60 to 69, 70 to 79, or more than 80 years of age. Gender, male or female. In ASA scoring, 1, 2, 3, 4, and then BMI, 19 to 24, 25 to 30, more than 30 or less than 19. The next is the intoxication. It includes alcohol drinking, smoking, and use of the steroids. And in neoadjuvant therapy, radiotherapy, or combination of the chemoradiotherapy. In elective or emergency, in case of emergency, it is due to bleeding or obstruction or perforation. And then distance of anastomosis to innervation is expressed in centimeter, more than 10, 5 to 10, less than 5. Then there is a present or not the additional procedures. The additional procedures like resection of the liver metastatic nodule or resection of the stomach in case of the CA transverse colon invading to the stomach. And the next is the blood loss or blood transfusion is expressed in male, less than 500, 500 to 2,000, 1,000 to 2,000, and 2,000 male, more than 2,000 male. And then duration of operation is expressed in hour, less than 2 hours, 2 to 3, 3 to 4, or more than 4 hours. According to the study, the highest score is 41 and lowest score is 0. Items included in CLS score are easily available from history of the patients preoperatively and some from intraoperative findings. The result of study will lead to the design of a protocol for post-operative monitoring to reduce the delay in diagnosis of anastomotic leakage and subsequent to reduce anastomotic leakage related to mortality. The main objective of the study is to study colon leakage score for predicting risk of anastomotic leakage in colorectal surgery. Method. This study was a hospital-based cross-sectional discrete study that addressed patients undergoing elective and emergency colorectal surgeries. Procedure involved both benign and malignant. Benign are resection of colorectal polyps, extending ischemia or infectious colitis, diverticular disease, colitis or Crohn's diseases. The malignant include both colonic or rectal cancer. Inclusion criteria were patients elder than 18 years of age undergoing elective or emergency colorectal surgery with anastomosis. Non-inclusion criteria were recurrent colorectal surgeries and elective stoma reversals. DJ procedure. All patients who underwent colorectal surgery with anastomosis were recruited in this study according to the inclusion criteria. All the patients were taken history and were undergone physical examination before operation, and intraoperative findings were checked. All the patients were monitored for anastomotic leakage by clinically and by imaging, at least ultrasound, and then recorded day by day. These data were filled in CLS scoring chart and then calculated to determine the possibility of anastomotic leakage. The main endpoint of this study was the efficacy of the score for early detection of anastomotic leakage in patients who had undergone elective or emergency colorectal resections. The efficacy was calculated by its sensitivity, specificity, positive and negative predictive values. Statistical analysis. After checking the consistency of the data, it was entered by using Microsoft Excel version 2007 and the version 13 statistical software. Frequency table was used for the qualitative variables. Diagnostic accuracy was then calculated. Results. A total of 93 patients were included in this study between November 2017 and October 2018. There were 44 males and 49 females. And there are 11 patients who had more than 11 points of chorolicase score. Among them, 5 of them got anastomosis leakage and the others not. And then 82 patients had less than 11 points of CLS score. Among them, only 3 patients got anastomosis leakage and the others not. Therefore, in patients with higher CLS points have a higher risk of anastomosis leakage, 45.45%. Overall anastomosis leakage rate was 8.6%. Regarding age, anastomosis leakage is more common in more than 70 years age groups, 21%, and rare in less than 30 years age group. Between 31 to 50 years of age, anastomosis leakage rate is 8%, and between 51 to 70 years of age, leakage rate is 5%. Therefore, the elder the age, the higher the risk of the anastomosis leakage. According to the gender, male gender has a higher risk of anastomosis leakage than female. Diagnostic performance. There were 11 patients with CLS score of more than 11 points and 82 patients with CLS score of less than 11 points. The incidence of anastomosis leakage following colorectal surgery was 8.6%. Among them, 62.5% of patients have score of more than or equal 11 points and got anastomosis leakage. The patients who had anastomosis leakage had a higher level of CLS scores than the patient who had no anastomosis leakage. So the sensitivity is 62.5%, specificity is 92.94%, so accuracy high, 90.32%. This table shows the sensitivity, specificity, and positive and negative predictive value. Their accuracy was high and expressed in purple color, 90.32%. Discussion. The principle of this study was to find out early the high-risk groups of anastomosis leakage in patients who underwent colorectal surgeries. CLS score can detect the risk of anastomosis leakage since before the end of the operation, because CLS score is calculated by using the data obtained from the history preoperatively and some from the intraoperative findings. When one patient is pointed to be high-risk group, surgeon can do the preventive procedures, such as a non-functional stoma to reduce the occurrence and the sensitivity of severity of the anastomosis leakage. And then that patient will also be closely watched and monitored for signs and symptoms of anastomosis leakage. Although the sample size was not too much, different age groups and different types of colorectal diseases, both benign and malignant diseases, are included. Different surgical procedures like open colectomy, laparoscopic colectomy, and laparoscopic rectal surgeries were all involved. Therefore, chorolicase score can be used as a tool to detect the high-risk patients for anastomosis leakage in colorectal surgery. These are my references. Thank you so much.
Thank you very much, Haniton, for your presentation. And second speaker, Santon Ao, he is also the surgeon from Manly General Hospital. So I'd like to invite Santon Ao for your presentation on early oral feeding in patients with mild acute pancreatitis. So Dr. Santon Ao, please. Thank you. We stop sharing right now.
Okay,
Good afternoon, Honorable Chairperson, Professor, Associate Professors, and invited guests. I am Dr. Santon Ao. I'm a Specialist Assistant Surgeon from Surgical Unit 1 from Manly General Hospital. I'd like to present about the early oral feeding in patients with mild acute pancreatitis. In introduction, acute pancreatitis is the defined acute condition presenting with abdominal pain and is usually associated with raised pancreatic enzyme levels in the blood or urine as a result of pancreatic inflammation. In mild acute pancreatitis, 70 to 90% of them usually resolve spontaneously in 5 to 10 days with conservative management. In conservative management, we usually treat the patient with nothing by mouth for oral feeding. The rationale for fasting the patient has been that the presence of food in the duodenum induces a cholecystokinin releases that stimulates pancreatic enzyme secretion. This concept of pancreatic rest is challenged by evidence from experimental animal studies and human trials demonstrating that the secretion of pancreatic juice and trypsin is reduced in acute pancreatitis. The objective of my study is to identify the proportional intolerance to early oral feeding in patients with acute pancreatitis and to determine the time of first flatus in patients who have early oral feeding and to determine the length of hospital stay. Methodology. My study is a hospital-based descriptive study that was carried out during the period from November 2017 to October 2018. It included 50 patients with confirmed acute pancreatitis. When the patient was confirmed with acute pancreatitis, the patients were assessed for the presence or absence of bowel sound. Then the patients were started early oral feeding regardless of the bowel sound. At first, clear liquid 100 ml was given 2 hourly from the mouth on admission day, and on day 2, clear liquid 200 ml was given hourly from the mouth, and on day 3, clear liquid at lips were given. If the patient suffered from vomiting and abdominal distension, the early oral feeding was stopped and patient was treated with the traditional management. Early oral feeding was gradually increased to semi-solid and a solid diet in a stepwise as tolerated by the patient. And the results show in 1 year period, 50 patients with migraine were recruited, and in the total of 50 patients, 2 patients are less than 20 years, and in the more than 60 years patient, there is 6 patients. The youngest patient was 19 years, and the oldest patient was 80 years old. According to my data, most pancreatitis patients are common in the middle-aged patient. And this figure shows the sex distribution of the patient, and 41 patients, that is 82% of patients were male. And this study, only 1 patient got vomiting and only 1 patient got abdominal distension after early oral feeding and needed to stop the oral feeding. And these 2 patients were treated with conservative management and there is no adverse outcome. A time of failure was evaluated after the first oral feeding. 43 patients passed failure within the first 24 hours, while the remaining 7 patients passed failure within the second 24 hours. And this chart shows the length of hospital stay. According to this chart, most of the patients were discharged from 3rd day and 4th day of the hospital stay. So conclusion, the results show that the 96% of patients with acute pancreatitis were compliant with early oral feeding, and incidence of complication was not much different from traditional management of bowel rest, and no serious adverse events and mortality were occurred during this study period. The length of hospital stay was 3.5 plus or minus 0.8 days in this study. This was significantly reduced than length of hospital stay of traditional management of the bowel rest. This means that the early oral feeding could enhance recovery and shorten hospital stays without increasing complication. Thank you for your attention.
Thank you, Santoa.
Oh.
Now, I would like to hand over the session to Professor Mumin for inviting the 3rd and 4th speakers. Thank you very much. Professor
Okay,
Mumin.
thank you, CI. Okay, thank you, CI Ujemye. So shall I go upon the 3rd speaker, who is Dr. Kang Suji from Surgical Unit 2 of Special Assistant Surgeon from Surgical Unit 2, who will represent the Helicobacter pylori infection in non-variceal upper GI bleeding.
Good afternoon, everyone. I am Dr. Kang Suji, Specialty Assistant Surgeon at Surgical Unit 2, now Global General and Teaching Hospital. I'm glad to participate in today's free paper session of 67 Myanmar Medical Conference. My topic is Helicobacter pylori infection in non-variceal upper GI bleeding. So first, I would like to start with how I get the idea to do this research. Non-variceal upper GI bleeding is a major problem encountered in daily surgical practice. Some studies have documented that H. pylori irrigation in upper GI bleeding prevent recurrent bleeding. leading cause of nephrosia by giant bleeding are peptic ulcer bleeding, gastric erosion, followed by gastric tumor bleeding. Although studies have documented that there is strong association of H. pylori with peptic ulcer and gastric cancer, there are variable results of the association of H. pylori with nephrosia by giant bleeding. So the aim of my study is to detect H. pylori infection in nephrosia by giant bleeding. This is hospital-based descriptive study done for 1 year from August 2017 to July 2018 at Sajike Ward of Now Glaba General Teaching Hospital. Study population is 75. All patients with nephrosia by giant bleeding who were confined on endoscopy are included in this study. And rapid urine test was used for the detection of Helicobacter pylori. The demographic data of the patient, the causes of nephrosia by giant bleeding, presence of H. pylori infection, relation between H. pylori infection and nephrosia by giant bleeding was studied. So here are the results. Figure 1 shows age distribution of nephrosia by giant bleeding. As we can see, nephrosia by giant bleeding is more common in the age group of 50 to 59 years. It was found in about 24% of the study population. In terms of male and female ratio, nephrosia is more common in the male population. Male to female ratio is about 2:1. Figure 3 shows the distribution of causes of nephrosia by giant bleeding. Gastric erosion was found the most among the nephrosia by giant bleeding. It was about 54.7%, followed by duodenal ulcer bleeding, gastric ulcer bleeding, and tumor bleeding in 4%. Since gastric erosion was the most common, we also documented the site of gastric erosion. Gastric erosion was the most common in the entrance region. It was about 46.34% in the entrance end. Diffuse gastric erosion was found 34.14%, and gastric erosion at the body was about 19.51%. This is the main result of my study. H. pylori infection was found about 65.3% in nephrosia by giant bleeding. It could be said that it was found in a larger population, about 2/3 of the study population. So what about the association of H. pylori with nephrosia by giant bleeding? It was shown in figure 6. The red line shows the urine test positive, and the green line shows the urine test negative. H. pylori infection was found about all positive in the tumor bleeding patient. We found 3 tumor bleeding patients in my study. In all three patients, H. pylori was found. Higher population of H. pylori was also found in duodenal ulcer patient. It was about 83.3%. H. pylori was also found in larger population in gastric erosion patient. It was about 56.1%. Figure 7 shows the relation between H. pylori infection and site of gastric erosion. H. pylori was found significantly lower in gastric erosion at the body, but it was found in larger amount in the erosion in the diffuse gastric erosion and erosion at the entrance region. Discussion. In this study, nephrosia by giant bleeding was most common in the 5th decade. The result was similar to study done by Telugu et al. In 2012. The mean age was 50 plus or minus 16.18 years in that study. According to these results, it could be said that nephrosia by giant bleeding was more common in the 5th decade. It could be due to increased consumption of NSAID aspirin in older population. So how about the male and female? Male to female ratio is 2:1%. There was a significantly higher proportion of men than women in patients with non-variceal aphasia bleeding in a study done by Anastasia et al. In 2008. It was about 65.7% in men and 34.3% in women. Gastric erosion was significantly higher, 54.7% in the current study, and the most common site of gastric erosion was entrance region, 56.4%. A majority of gastric erosion cases give a history of anesthetic use or alcohol drinking. It may be the reason for why gastric erosion was more common. But the study done by Anastasia et al. In 2008, bleeding due to peptic ulcer was the most common, followed by the gastric erosion. In other study, gastric erosion at the entrance region was also the most common. It was consistent with my study. In this study, Helicobacter pylori infection was found to be present in 65.3% of the total population. There is no previous study recording the presence of H. pylori infection in non-variceal aphasia bleeding in Myanmar. In a retrospective study of H. pylori infection aphasia bleeding in Thai patients, the prevalence was 27%. The result was different from other studies. It could be due to high prevalence of H. pylori infection in Myanmar population. The overall prevalence of H. pylori in Myanmar population was 68.8%, and a study done by Milken in 2002. The association of H. pylori with gastric erosion was statistically not significant. It may be due to other factors like alcohol and NSAID use, which also contributed to the cause of gastric erosion. The association of peptic ulcer bleeding and H. pylori were statistically not significant in this study. It may be due to smaller number of sample size. So my conclusion is high prevalence of H. pylori infection was found 65.3%. There was association of H. pylori with enteral gastric erosion. H. pylori infection should be tested in patients with gastric erosion at the enteral region. The association of H. pylori with other causes of non-variceal aphasia bleeding needed further study. And test and treat strategy for H. pylori should be practiced to prevent recurrent bleeding. These are my references, and thank you all for your attention.
Thank you, Dr. Kainsuji, for your very interesting presentation. So I will go upon the next speaker, Dr. Yetel, who is a specialist assistant surgeon from Surgical Unit 1 of North Oklahoma General Hospital. And he is presenting ultrasound-guided percutaneous catheter drainage in liver abscesses.
Good afternoon. Today I would like to present my paper, Ultrasound-Guided Percutaneous Catheter Drainage in Liver Abscess. Introduction. Over the last 2 decades, outcomes in patients presented with liver abscess has improved as a result of advances in radiological diagnosis and percutaneous treatment options. Currently, patients are treated with antibiotic along with percutaneous needle aspiration or percutaneous catheter drainage. Surgical drainage is used only in patients who fail to respond to such treatment. Antibiotic therapy has also improved, but the principal advance in the management of hepatic abscess has been the application of percutaneous aspiration technique for diagnosis and treatment. And this study was done to evaluate the effectiveness of ultrasound-guided percutaneous catheter drainage in the treatment of liver abscess in North Oklahoma Teaching General Hospital in St. Anthony General Hospital. Methods. This study was a hospital-based prospective study done within a year period after approval. To the patients of 33 from 3 hospitals were enrolled for the study. All patients with liver abscess more than 5 centimeters were included. The exclusion criteria are hemodynamically unstable patients with coagulopathy, technically difficult access area or liver, abscess cavity with septation, and multiple liver abscess, recurrent bacterial cholangitis, and malignant disease of the liver. Petri catheter was introduced into the abscess cavity using the Truca method. Under aseptic condition and local anesthesia, diagnostic aspiration was done to confirm the pus, and this indicates depth and duration to assess liver abscess. Skin incision was made with 11 blades. 12-French Truca and cannula was inserted through the skin incision to the abscess cavity under ultrasound guidance. Pus came out when the Truca was removed. The catheter, 12-French Petri catheter, was introduced into the abscess cavity through the cannula. The cannula was then removed. Aspiration was performed with the catheter until normal pus could be aspirated. Abscess cavity was irrigated with normal saline, and the catheter was secured to the skin with a stitch. The catheter was connected to a drainage bed. Sterile dressing was applied. The catheter was removed when the patient is clinically improved, when the catheter output becomes serious or less than 10 ml in 24 hours, and reduce in size or collapse of the abscess cavity without any residual pus by ultrasound. Findings. Most of the patients were aged between 31 and 40 years, 8 patients, 24%. Followed by the age group between 41 and 50 years, 7 patients, 21%. The mean age of the patient was 46 years. Out of the 33 patients with liver abscess, 26 patients, 78% were male, and the rest 7 patients, 21% were female. On ultrasound findings, liver abscess were found at the right side with 31 patients, 93%, and at the left side in 2 patients, 6%. Most of the patients got aspiration of pus amount more than 500 ml, 9 patients, 27%, followed by the pus amount of 150 to 200 ml, 7 patients, to that 21%. The mean pus amount of the patient was 394 ml. All the patients with amoebic liver abscess had 2 to 9 days of hospital stay. Pyogenic liver abscess group, 3 to 6 days of hospital stay. Most of the patients with amoebic liver abscess had a 50% reduction in cavity size after catheter drainage at day 6, 31%. In pyogenic group, 50% reduction in abscess cavity size after catheter drainage at day 6, 50%. All patients with pyogenic liver abscess were discharged and cured. Out of 29 patients, amoebic liver abscess, 27 patients were discharged and cured, 93%. 1 patient got peritonitis, 3%, 3.4%, and 1 patient got blocked catheter, 3.4%. There was no mortality in both pyogenic and amoebic liver abscess. Discussion. Percutaneous treatment needed aspiration or catheter drainage is known as standard treatment for liver abscess, Raja et al. 1998. His study and another study done by Giorgio et al. 1995 also stated that needle aspiration has lower success rate than catheter drainage. Another problem with needle aspiration is that repeated needle aspiration may be required in a single patient over a short period of time, 5 to 14 days, Raja et al. 1998. It may be painful or unpleasant for the patient and is unacceptable to them. To avoid these problems with needle aspiration, percutaneous Petri catheter drainage is now used as the first tool in the management for liver abscess. The advantage of catheter drainage is that it provides a continuous outlet for the pus, and the problem of incomplete or repeated evacuations are not required. The outcome of this study was assessed with discharge, complications, and mortality. There was no mortality in this study. In this study, 31 patients were discharged and cured without minor complications. 1 patient got peritonitis after catheter drainage. This occurred during the introduction of trocar needle into the abscess cavity and caused minor leakage of pus from the abscess cavity. Another patient got blockage of catheter 1 day after insertion of catheter due to thick viscosity nature of the pus and slash of the abscess cavity wall. Flushing when normal saline and ultrasound guided recheck of the catheter position was done and solved the blockage. But none of these patients were delayed in hospital stay and no complications at follow-up ultrasound recheck examinations. Discussion. Sumit Kapadia at the 2002 reported percutaneous catheter drainage is a safe procedure with very few reported complications. This study did not have any major complications, although minor complications were 40%, 10 patients. Minor complications were catheter blockage, catheter dislodgement, tract pain, and infection. There was no mortality associated with the procedure in his study. Severe ultrasound assessments were done to all patients every 2 days during catheter drainage and every 2 weeks for 1 month after discharge for the response of the treatment. Ultrasound resolution of an abscess cavity following the procedure may occur at any time between 2 weeks to 4 months in Giorgio et al. 1998 and Raw et al. 1983 studies. Sumit Kapadia's study showed small residual cavities may persist indefinitely and 40% of his patients had small residual cavities, less than 2 cm at 3-month follow-up. In Winchell 2002 study, most of the lesions disappear on ultrasound at the end of 3rd month. Another important factor for petecatheter drainage was the cost. However, the advantages of the percutaneous drainage made the cost for the patient or for the hospital justifiable. Conclusion. Changing trends of treatment in liver abscess are directed toward less invasive methods like percutaneous catheter drainage and needle aspiration and medical treatments. This study highlighted the prevalence of age, gender, clinical data, and results of liver abscess, and outcomes and complications of percutaneous catheter drainage method. Although this was a small sample size study with short duration, it showed rapid improvement of percutaneous catheter drainage method, like 50% reduction in cavity size and hospital stay after catheter drainage. And this data showed the length of hospital stay after catheter drainage. Amoebial liver abscess group, the range of the hospital stay are 2 to 9 days. And pyogenic group, range is 3 to 6 days. And this data show the times of 50% reduction in abscess cavity after catheter drainage. Amoebial liver abscess group, the range is 4 to 28 days for the 50% reduction in cavity size. In pyogenic group, it took 6 to 28 days. These are the photographs of the patient enrolled for the study with their permission. And these are the reference. And thank you for your kind attention.
Thank you, Dr. Yete, for your brilliant presentation. Now, I'd like to call upon Dr. Tess Denue from Institute of Medicine 2 regarding the topic on the effect called tenisemic acid on the seroma formation after the modified radical mastectomy. So, Dr. Denue, please, for your presentation.
Thank you, Siaji, for your kind invitation of me. Good afternoon, Honorable Chairperson, Professor, Associate Professor, Consultant Senior Juniors, and my colleagues. I'm Dr. Denue, Assistant Lecturer from Department of Surgery, University of Medicine 2. It's my great pleasure to have a chance on free paper presentation of today's conference. My topic is effect of tranexamic acid on seroma formation following modified radical mastectomy. Breast cancer is the most common cancer in women and second cause of cancer death worldwide. Total mastectomy and axillary clearance is the most commonly performed operation in Myanmar. The most common morbidity is the post-operative seroma formation. We have done several interventions to reduce the formation of seroma formation, like usage of compression bandage and session drain, but none of them proved the significant reduce in seroma formation. By administration of tranexamic acid 500 milligram 8 hourly for 1 day intravenously, followed by oral tranexamic acid 500 milligram TDS for 5 days, amount of seroma formation is significantly reduced. That's why by the use of simple tranexamic acid, seroma formation and wound complications can be reduced dramatically. Therefore, our patients can return to normal daily activities rapidly and can proceed to adjuvant therapies early. The aim of my study is to compare the seroma formation following total mastectomy and axillary clearance with or without tranexamic acid. Objectives are to assess the demographic distribution of carcinoma of breast, to assess the amount of seroma formation in study group, and to assess the amount of seroma formation in control group. And the last one is to compare the seroma formation between study group and control group. Introduction. For women, lifetime risk of developing breast cancer is 11%, and surgery still has a central role to play in management of breast cancer. The most common morbidity after total mastectomy and axillary clearance is the seroma formation. And other complications like flek necrosis, infection, shoulder stiffness, and lymphedema are consequence of seroma formation. Seroma formation is thought to be the collection of liquefied fat, serum inflammatory exudates, and lymphatic fluid under the skin flap. The fluid is serosanguinous in immediate postoperative period, and later on, it usually became clear, yellow, and somewhat viscous. It is influenced by many factors like extent of mastectomy, extent of lymph node dissection, and method of skin flap dissection, such as usage of therapy or knife. Seroma can be categorized as postoperative total wound drainage before removal of the drain and the lymph flap collection seroma after removal of the drain. The incidence of seroma formation is 30%. So what about tranexamic acid? It is the synthetic antifibrinolytic agent and also has a direct antiplasmic action, inhibiting fibrin degradation. It also protects fibrin arises from a direct change in the conformation of fibrinogen. Administration of postoperative tranexamic acid in carcinoma of breast patient who underwent total mastectomy and level 2 axillary clearance resulted in significant reduction in mean postoperative drainage volume. My study is the hospital-based comparative study. Study period was from 1st January 2017 to 31st December 2017. Total sample size was 36 patients, and patients were divided into two groups. Group 1 is study group, in which include patients who received tranexamic acid, and group 2 is the control group, patients who did not receive tranexamic acid. These are the results of my study. Each distribution of patients with breast carcinoma in two groups, there was no significant difference. The youngest age in my study group is 39 years old and oldest age is 56 years old ladies. And this table shows the tumor size distribution of patients with breast carcinoma in two groups. In the study group, 10 out of 18 patients are T3 staging, tumor staging, and remaining 8 are T4 tumor staging. And in control group, half T3 size and remaining half T4 size. This shows the tumor staging distribution of patients with breast carcinoma in two groups. Here we can see that there was no significant difference in tumor size in both groups. This is show the lymph node status distribution of patients with breast carcinoma in two groups. And here we can see the lymph node status distribution in both group N1, N2, and N3 staging. On respect of the postoperative complications, 2 out of 18 patients in study group encounter seroma formation and 4 out of 18 in control group encounter seroma. Luckily, there was no report of hematoma, flap necrosis, and wound infection during my study period. This table shows the association between itch and seroma formation after breast cancer surgery. P-value is 0.221. And this shows the association between tumor size and seroma formation after breast cancer surgery. There was no significant difference on the spread of the seroma formation in both groups regarding with the tumor size staging. And this figure shows the association between lymph node status and seroma formation after breast cancer surgery. This table shows the amount of wound drainage in compare of two groups. In study group, median amount was ranging from 80 to 150 ml, and in control group, median amount was ranging from 100 to 200 ml, and p-value was less than 0.01. So here we can say that amount of wound drainage from tumor bed was significantly reduced in study group with tranexamic acid. This table shows the amount of wound drainage from axillary fossa. Also, p-value is less than 0.01, and amount of wound drainage from axillary fossa is significantly reduced in study group with tranexamic acid. This shows the duration of wound drainage. In study group, mean duration was 4.3 plus or minus 0.8 days, and in control group, 4.8 plus or minus 0.4, around about 5 days. So p-value is less than 0.01 and statistically significant. So duration of wound drainage in study group is relatively shorter than the control group. This is the hospital-based cross-sectional study, which was carried out in Miao Kalapa and Tenganjon and Insing General Hospital to find out the effect of tranexamic acid on seroma formation following modified radical mastectomy. There was no significant difference in seroma formation according to age, tumor status, and lymph node status in both groups. On the point of view from duration of wound drainage, mean duration of study group and control group were 4.3 plus or minus 0.8 days and 4.8 plus or minus 0.4 days. Mean duration of wound drainage was found to be significantly lower in study group than the control group. This study showed that patients who received tranexamic acid has lesser wound drainage at both tumor bed and axillary fossa, lesser duration of wound drainage, lesser needed aspiration than the patient who did not receive tranexamic acid. As post-operative complication, seroma formation was found in both groups, 2 patients from study group and 4 patients from control group, although it is not statistically significant. So let me conclude my presentation. Breast cancer is the most common cancer in women and is the second cause of cancer-related deaths worldwide. For women, lifestyle risk of developing breast cancer is 11%. Surgery still has a central role to play in management of breast cancer. The most common morbidity after total mastectomy and axillary clearance is the seroma formation. This study showed that age of patient, tumor, and lymph node stage did not affect the seroma formation. Moreover, patients who receive tranexamic acid has less wound drainage at both tumor bed and axillary fossa, less duration of wound drainage than the patient who did not receive tranexamic acid. Therefore, tranexamic acid may be used to reduce the frequency of post-operative seroma formation following surgery for breast cancer. These are my reference for my study. Thank you all for your kind attention.
Thank you very much. Professor Mumni, please.
Thank you. I will go upon the last, but not the least speaker, Dr. Gigi He, who will be presenting an interesting topic, outcomes of hemorrhoidectomy. Dr. Gigi He, please.
This was session. Good afternoon, Professor, Associate Professor, my senior and junior college. Today, I would like to present about my paper outcomes of hemorrhoidectomy. As my introduction, hemorrhoids are engorged vascular cushions found within the submucosa of the inner canal. They consist of circulated venous plexus with a rich arterial blood supply supported by fibromuscular connective tissue. Hemorrhoids is very common condition and is treated by many various different methods of physician using different methods depending on their country and local clinical practice. Hemorrhoidectomy is considered to be a painful operation. Frequent recurrence and discomfort after hemorrhoidectomy are the biggest problem. Ideal operation for hemorrhoids should be safe effectively with the low rate of recurrence and minimal post-operative pain. Regarding the recurrence, conventional hemorrhoidectomy is accepted the gold standard. It is associated with significant post-operative pain, perineal discharge, and irritation. So, innovation and evolution in hemorrhoidectomy techniques have been focused on the achieving the ideal operation. Aims of the MIND paper is to study outcomes of hemorrhoidectomy. Objective has three components. Firstly, to identify the demographic data, and second, to describe the clinical presentation of the patients. Third, to assess the outcomes of hemorrhoidectomy patients. Methods were hospital-based cross-sectional descriptive clinical study. Study periods were 1 year study period, study from 1st January 2017 to 31st December 2018. Study area was surgical ward of Magwe Regional Hospital and Magwe Teaching Hospital. Sorry. This is the algorithm for my paper. Firstly, I collect the patients who underwent the hemorrhoidectomy and take it informed consent. After taking informed consent, I will take the, I took the history taking and examination. After history taking and examination, I can rule out the demographic data of the patient included in my paper and assess the outcomes, including wound healing, hemorrhage, recurrent incontinence, and stenosis. These are the results of the MIND paper. Firstly, age distribution shows that common age group of the MIND paper was between 41 years and 60 years of age. Second common age group was the 21 and 40 years. This is the sex distribution of the MIND paper. Sex distribution shows that male are more prevalent than the female, but this is not significantly different. These are the occupational status. First, most common age group was the farmers, and second common age group was their own business. These are the clinical presentation of the hemorrhoids in patients. Third degree was most common and second degree was second common. Clinical presentations of the MIND patients show common presentation, bleeding by rectal and anemia. A few patients presented with the prolapse. 3 types of the hemorrhoidectomy were done. Firstly, open hemorrhoidectomy. Second, closed hemorrhoidectomy, and thus stable hemorrhoidectomy. 114 patients were included in my paper. Almost all of the patients were treated by open hemorrhoidectomy. Only 2 patients were treated by stable hemorrhoidectomy and 1 patient were treated by closed hemorrhoidectomy. The outcomes of the hemorrhoidectomy were assessed. Most of the patients were complicated with the delay wound healing, about 30 patients. Second common complications were the hemorrhage. Conclusion, total 140 patients underwent hemorrhoidectomy and 111 patients were treated by open hemorrhoidectomy and 2 patients were treated by stable and the rest was treated by the closed hemorrhoidectomy. Most of the patients in my paper was presented with the common presentation, bleeding by rectal and anemia. age and sex distribution was not significantly different. The most common complication in my study was delayed wound healing, and second most common complication was bleeding. The two complications were occurred in the open hemorrhoidotomy patients. Only one patients were treated by closed hemorrhoidotomy, and these patients were complicated by the anal stenosis. There was no complications in stable hemorrhoidotomy, but it was only 2 patients due to limited facilities. Conclusion: stable hemorrhoidotomy should be practiced as it is superior to open and closed method because of reduced bleeding, stenosis, and no occurrence of the stenosis and favored wound healing. But my study does not definitely conclude that which method is more effective and less complicated because a very small sample size of the closed and stable method. We point out that my study was single center study with modest sample size, lack of information about the post-operative pain. Post-operative pain is very common in the hemorrhoidotomy operation. Therefore, efforts should be made not only to find out the outcomes of the 3 methods of hemorrhoidotomy with large population in various centers, but also to evaluate new options of the hemorrhoidotomy. These are my references. Thank you for your kind attention.
We're going to be a Shija Ramdi. Samuru, General so be Nija. No job is Savio, so be Nija. Piosia, you go. Samu Jalam Divia. When in a Savi, Miguni, Michi, on some maybe like Mateo Chimbo. Then I'm Yanamang out. Colon leakage schools we have Theo, a school my body bias we have Honeyton briefly body bias we have web to Piazama.
Okay, Basia. Dicaro the mere school parameters and in a solution or set up Pupa. Manticaro age, Nika says, Tonga ASA scoring, Leah BMI. Intoxication မှာတော့သူရဲ့ဟာတွေကအရက်တောက်လားဆေးလေးတောက်လား steroid တွေတောက်နေလားပေါ့ပြောတာပါဆရာကြီးပြီးတော့ခါကျတော့ neoadjuvant therapy ပေါ့အရှိမ chemo radio တွေပေးထားလားရယ်ပြီးတော့ခါကျတော့ elective လား emergency လားရယ်ပြီးတော့ခါကျတော့ distance of anastomosis to anal vash ပေါ့ဘယ်လောက်กว่าလဲဆိုတော့ဟာကို centimeter နဲ့မှတ်ပါတယ်ဆရာကြီးပြီးတော့ခါကျ additional procedure ပေါ့နောက်တစ်ခုကအဲ့ additional procedure ဆိုတာကကြတော့ခွဲနေရင်နဲ့လက်ဟမီရေလုံနေနဲ့ liver metastasis မှာအနိုဒူးလေးရတခါရဖြတ်လိုက်တာတော့ဒါမှမဟုတ်လို့ရှင်လဲ CA transverse colon ခွဲနေနဲ့ CA stomach invasion into the stomach ကိုတခါရpartial gastrectomy လုပ်တာတို့တွေကိုပြောတာပါရှင်ပြီးတော့ခါကျ blood loss ဒါမှမဟုတ်လို့ရှင်ရင် intra-op မှာသွင်းလိုက်ရတဲ့ blood transfusion ကိုကတော့ male နဲ့မှတ်ပါတယ်ဆရာကြီးပြီးတော့ခါကျတော့ operation duration ကိုကတော့ hour နဲ့မှတ်ပါတယ်ဆရာကြီးအားလုံးစုပေါင်း11 parameter ပါရှင်
အဲ့ဟိုabout distance from anastomosis to anal margin ပေါ့အဲ့ကဘလောက်ဆိုရင်တော့ leakage ပို့ပြီးတော့ရနိုင်တယ်လို့ထွက်တော့ school က more than 11ဆိုရင်တော့ထွက်တာပေါ့လေဒါပေမဲ့ distance ကဘယ်လောက်ရှိလဲ
ဟုတ်ကဲ့ဆရာကြီးသူကတမီးရဲ့တွက်ထားတဲ့ data တွေထဲမှာဆိုလို့ရှိရင်တော့သူက3ပိုင်းပေါ့ဆရာကြီး more than 10ဆိုလို့ရှိရင်တော့တမတ်0ပေါ့5 to 10 cm ဆိုရင်တော့3မှတ်ပေးရ less than 5 cm မှာဆိုတော့6မှတ်အနေနဲ့တွက်ပါတယ်ဆရာကြီးအဲဆိုတကယ်လို့ဒါ patient ကတော်တော်လေးကို ultra low AR ပုံစံမျိုးလုပ်ရပြီးတော့မှ less than 5 cm ဆိုရင်တော့ပို့ပြီးတော့ခါကျတော့ risk leakage rate ပုံများတာကိုတွေ့ရပါတယ်ရှင်ဆရာကြီး
တမီးရဲ့ technique study မှာhands-on anastomosis နဲ့ stapling ကတော့သုံးတာနဲ့ဟာအဲ့ stapler သုံးတာနဲ့အဲ့လိုခွဲခြားထားတာမရှိဘူးเนาะ school တွေမှာမပါဘူး
ဟုတ်ဆရာကြီးခွဲခြားထားတာမရှိပါဘူးဆရာကြီးဘလို့နည်းနဲ့ပဲဖြစ်ဖြစ် laparoscope နဲ့ပဲလုပ်လို့ open မဲ့လုပ်လို့ hands-on မဲ့လုပ်လို့ stapler ပဲလုပ်လို့ဆိုပြီးတော့ခါကြတော့မှအဲ့ဒီ technique ဟိုကတော့လစ်လူရှုထားပါတယ်ဆရာကြီးဟုတ်
ကျွန်တော်နည်းနည်း second speaker ကိုတွားလိုက်ပြီเนาะစံထုံးအောင်အဲ့ဒီကပြောတဲ့ပြီးရင်ဆရာမိုးလဲလိုအပ်တာရှိထပ်ဆွေးနွေးပြပါအောင်နော်
ဟုတ်တယ်
second speaker စံထုံးအောင်ကသူက early oral feeding မှာ acute pancreatitis ပေါ့နော်အဲ့တော့တကယ်ရော practice ပေါ့ clinical practice မှာလုပ်လို့အဆင်ပြေလား
ဟုတ်ကဲ့ပါဆရာခင်ဗျဟုတ်ကဲ့ဆရာဟိုအဆင်ပြေပါတယ်ဆရာကျွန်တော်တို့ဒီမှာလည်းဒီ session 1 2 3ဟိုတော့လုံးမှာလည်း early order feeling ကဟို pancreatitis my patient တိုင်းမှာပေးနေပါတယ်ဆရာခင်ဗျဟုတ်ပြီးတဲ့အချိန်မှာလည်း patient တော်တော်များများဒီ tolerable ဖြစ်တော့တွေ့ရပါတယ်ဆရာ
ဟုတ်ပါတယ်first speaker ပေါ့ခိုင်စုကြည့်နော်မရှိရနော်H pylori infection and non-peripheral upper GMB ပေါ့ဟုတ်လားအဲ့တော့ enterogastritis နဲ့ gastric erosion နဲ့အဲ့နဲ့သွားဆက်ဆက်တယ်ထင်တယ်ဟုတ်လား H pylori က
ဟုတ်ကဲ့ပါ
အဲ့ခါကျတော့တမီးအနေနဲ့ပေါ့နော်ဒါဆက်ဆက်မှုကိုတွေ့ပြီဆိုတဲ့ခါကျရင်ဒီ study ရဲ့ impact ပေါ့ H pylori eradication ကို advice လုပ်ချင်လားပေါ့အဲ့ဒီသိချင်လား
ဟုတ်ကဲ့ပါဆရာကြီးဒီ erosion ဖြစ်တဲ့ patient တွေပေါ့နော်ဆရာကြီးအများဆုံးလာတဲ့ဟာကြတော့ဟိုအသက်ကလည်းငယ်သေးတယ်ဆရာကြီးပြီးတော့အခုနောက်ပိုင်းကကြတော့တွေ့လာရတာကြတော့သူကကြတော့gastric cancer တော့ပေါင်းနေလေ H pylori association လည်းရှိရဆိုတော့အဲ့ဒါကြောင့်အဲ့ဒါတစ်ချက်ပေါ့နော်နောက်တစ်ခုကကြတော့eradication လုပ်လိုက်ရင်ကြတော့ bleeding patient တွေမှာဆိုရင်ကြတော့သူက recurrent bleeding ကာကွယ်နိုင်တယ်ပေါ့နော်အဲ့ဆိုတော့သမီးအနေနဲ့အခု finding ရဆိုတဲ့ဟိုပါပေါ့နော် recommend patient မှာဆရာကြီး H pylori test လုပ်တင်တယ်ပြီးတော့ကြတော့ eradicate လုပ်တင်တယ်ဆိုပြီးတော့
အဲ့တော့ follow up အနေနဲ့ပေါ့နော်သမီးအနေနဲ့ဘယ်လောက်ပြန်ခေါ်ရင်ကောင်းမယ်ထင်တယ် follow up eradication လုပ်ပြီးသွားပြီကွယ်လုပ်ပြီးသွားတဲ့ခါကျရင်ဘယ်လောက်နေ follow up ပြန်ခေါ်ရင်ကောင်းမယ်ထင်တယ်
follow up ကကြတော့ပြောရရင်ဒီမှာတော့ follow up ကကြတော့ဟိုအားနေပါတယ်ဆရာကြီး follow up ကြီး patient နေရနောက်တစ်ခါဟို scope ကြည့်ဖို့လေ persuade လောက်ကြတာလည်းနည်းနည်းတော့ခက်တယ်ဆရာကြီးအဲ့တော့ဟိုခေါ်မယ်ဆိုရင်တော့တစ်လားလောက်ကြာရင်တော့ပြန်ခေါ်ခြင်းပါတယ်ဆရာကြီးစေးတောက်ပြီးတော့နှစ်ပတ်ဆို
eradicate တကယ်ဖြစ်မဖြစ်ဆိုတာတော့ပြန်ကြည့်ဖို့လိုတာပေါ့နော်။ဒါပြကောင်းပါလေ study လေးရလေနော်
။ဟုတ်ကဲ့ပါ
။ဒေါက်တာရဲထဲအောင်ဆရာနည်းနည်းစပေးလိုက်မယ်နော်။ liver abscess ပေါ့ biogenic ကို amoebic ကိုနှစ်ခုလုံးပါတယ်ပေါ့နော်။ဟုတ်လား။အဲ့တော့ဆရာသိချင်တာမကာမှတ်ပြီးမှကိုယ့်အတာကိုဓမ္မဆရာဝင်မရှိဘဲနဲ့ expression လုပ်တာလား။ဒါမှမဟုတ်လေ in the presence of radiologist လုပ်တာလား
။ပထမဆုံးဟုတ်ကဲ့ဆရာပထမဆုံး ultrasound ရိုက်ပါတယ် liver abscess confirm ဆိုတာနဲ့ ultrasound department မှာprocedure လုပ်ဖို့အရင် date ပြန်ယူပါတယ်ဆရာယူပြီးတော့မှreal time ultrasound guidance နဲ့ကိုထည့်ပါတယ်ဆရာ
ကြီးအဲ့ဒါတော့တော်တော်ကောင်းတယ်
ဟုတ်ကဲ့
အဲ့လိုလုပ်မှဖြစ်မှာဆရာတို့ရတခါကျအဆင်ပြေခဲ့တယ်ကိုယ့်အကူမကမှတ်ခိုင်းလိုက်ပြီးတော့လုပ်တာမျိုးရှိတာပေါ့နော်
ဟုတ်ကဲ့ပါ
အဲ့တော့အားသာချက်ကတော့ဓမ္မဆရာဝင်ဘေးနားမှာရှိတဲ့ခါကျရင်ပတ်စာကုန်မကုန်တကယ်တမ်းသိတာပေါ့
ကြည့်ပေးပါဆရာ
ဒါမျိုးဓမ္မဆရာဝန်သားမရှိဘူးဆိုရင် expression လုပ်နေရင်ဘယ်အချိန်ကျရင်အဲ့ expression ကိုဆရာကတိတာလေးထည့်လိုက်တာနော်ဟုတ်တယ်နော်
ဟုတ်ကဲ့ပါဆရာ
ကတိတာထည့်ရတဲ့ expression လုပ်တာလည်းတော့မတူဘူးပေါ့ကတိတာ size ဟိုအမျိုးအစားလို့ size ဆိုကြဆရာဘယ်လိုဆုံးဖြတ်တော့
petri catheter သုံးပါတယ်ဆရာကြီး size ကိုတော့ဟိုအရင် previous study တွေကသုံးတဲ့ 12 ကိုသုံးထားပါတယ်ဆရာကြီး
size hole လေးတော့အထက်ဒီချာထည့်ရမှာပေါ့နော်ဆရာဒါမင်းအဲ့ပြီးရင် irrigation လုပ်သေးလား
irrigation normal saline နဲ့လုပ်ထားပါတယ်ဆရာ
normal saline နဲ့လုပ်တယ်နော်အေးဟုတ်ပါပြီးရင်ဆရာမိုးလည်းမေးစရာရှိအောင်ပါနော်number 5 speaker ပေါ့ဒေါက်တာသိန်းသူဝေပေါ့နော် tranexamic acid ကို cerebral formation နဲ့ပေါ့နော်အဲ့ဆရာသိနေတာလေဟိုပေါ့ drain ထည့်ထားတာရှိမှာပေါ့နော် drain ကဘယ်နှချောင်းထည့်လဲမသိဘူး breast ထဲကိုနှစ်ခုလားတစ်ခုလားအဲ့ဒါသိချင်တာ
သမီး2 drain ထည့်ပါတယ်ဆရာကြီးရှင့်ဟုတ်
များသောအားဖြင့်အတွေ့အကြုံရလေဘယ် drain ကထွက်နေတာနောက်ကျမှဖြုတ်ရတာများတော့
exhala ပုံများပါတယ်ဆရာကြီး
exhala ပုံများတယ်နော်အဲ့တော့ဟုတ်ပြီအဲ့တော့အဲ့ဒီအချိန်မှာဒီ surgeon ရဲ့ဒီ mastectomy လုပ်တဲ့အချိန်မှာ diatemy သုံးခြင်းမသုံးခြင်းနဲ့ရော cerebral formation ကဆိုင်မယ်လို့ထင်လား
ဆရာကြီးသမီး paper မှာတော့ဆရာကြီးဟို diatemy သုံးတဲ့စာချင်းရော knife သုံးတဲ့စာချင်းရောနှစ်ခုလုံးကောက်ပါတယ်ဆရာကြီးဟုတ်
အဲ့တော့ဘာများကို objective ပါလာမပါပေမဲ့လေဒါပေမဲ့ဘယ်လိုများသတိထားလိုက်မိလဲမသိဘူး cerebral formation ဘယ်မှာပိုဖြစ်တယ်ထင်တော့စာရပေါ့
ဟုတ်ဆရာကြီးဟိုတကယ်လက်တွေ့မှာတော့ဆရာကြီးသမီး senior တွေအမတွေဆရာတွေအကုန်လုံး diatemy နဲ့တွားတာများပါတယ်ဆရာကြီးရှင့်ဟိုသမီးအရင်သမီး paper နဲ့တူတူအရှိမ paper နှစ်ဆောင်မှာတော့သူတို့ knife နဲ့အဲ့ဒီ electrocautery နဲ့ကိုရှင်းထားတာရှိပါတယ်ဆရာကြီးအဲ့မှာတော့ဆရာကြီးဒီ cerebral formation က affected အဲ့ဒီ significant difference မရှိဘူးဆိုတဲ့ paper တစ်စောင်ရှိပါတယ်ဆရာကြီးဟုတ်
အဲ့တော့ဟိုပေါ့ follow up ကိုဘယ်လောက်နေပြန်ခေါ်လဲမသိဘူးသမီးက
follow up ကိုဆရာကြီး6 month ထိခေါ်ပါတယ်ဆရာကြီး
re-aspiration လုပ်ရတာမျိုးတွေရောရှိလား
respiration ရှိပါတယ်ဆရာကြီးဟုတ်ကဲ့ပါဆရာကြီး
drain ကကြတော့ဘယ်လောက်နေဖြုတ်လိုက်တော့
drain ကဆရာကြီးသမီး less than 30 mil နဲ့ဖြတ်ပါတယ်ဆရာကြီးသမီး less than 30 mil for 24 hours ဆိုသမီး drain out ပါတယ်ဆရာကြီး
ဒီကို bacon drain လေးကိုလောက်တာလားဒါမှမဟုတ်2060 swing ဆိုဟာမျိုးနဲ့တက်ပြီးတော့စုပ်တာလား
ဆရာကြီးအဲ့ဒီဟိုဒီ steady မှာတော့ဆရာကြီးသမီး vacuum drain သုံးပါတယ်ဆရာကြီးဟိုလက်ပစ်ဘုံလေးဟုတ်
ကျေးဇူးပါပဲနော် last speaker ပေါ့တော်တော်ကြီးဟန်ပေါ့နော် hemorrhagectomy ပေါ့နော်သမီးရဲ့ဟိုထဲမှာ presentation မှာတွေ့တာ stapler သုံးတဲ့ဟာ2ယောက်ပါတယ်နော်ဟုတ်တယ်နော် stapler သုံးတဲ့2ယောက်ပါတယ်ဆိုကြတော့ surgeon တွေကပေါ့နော်အကြမ်းပြင်းအဖြစ်ဘယ် case ကို open လုပ်မယ်ဘယ် case ကို close method လုပ်မယ်ဘယ် case ကို stapler လုပ်မယ်ဆိုပြီးတော့ဆုံးဖြတ်တယ်ထင်တော့
degree ပေါ်မှာမူတည်ပြီးတော့ဆရာကြီး
ဒီပေါ်မှာမူတည်ပြောပါဦး
degree ပေါ်မှာမူတည်ပြီးတော့ဆုံးဖြတ်ပါတယ်ဆရာကြီး degree ပေါ်မှာမူတည်ပြီးတော့ဆုံးဖြတ်တာဟို most of the patient ကကြတော့သမီး study မှာပါတဲ့ patient တွေကကြတော့ conventional method ဖြစ်တဲ့ open ကိုပဲသုံးလိုက်တာပါရှင်ဆရာကြီးပြီးတော့ကြတော့
ပြောပါဦး
ပြောပါဦးကကြတော့ facility ကလည်းနည်းနည်း limited ဖြစ်တော့ကြတော့2ယောက်ပဲဖြစ်သွားတာရှင်ဆရာကြီး
အေးပေါ့ဈေးလည်းကြီးတာဟုတ်ပြီနောက်ပြီးတော့ stapler ကြတော့လေပြီးတော့30 degree ပိုင်းဆိုဟာမျိုးပေါ့နော်ဒီပြုတ်ထွက်နေဟာမျိုးကျန် stapler နဲ့လုပ်လို့ရလားတမီ stapler ဘယ်လောက် degree ပိုင်းမှာလုပ်လိုက်တာလည်းမသိဘူးနော်
second degree ပါရှင်ဆရာကြီး
second degree ပဲ
ဟုတ်ကဲ့
ဆရာဒီတိုင်းပြလိုက်တာတခုပေါ့ close method မှာ anal stenosis ရတယ်ဆိုပြီးတော့တွေ့လိုက်တယ်နော်အဲ့ဒီ patient သူကဟိုပေါ့ 3711ပတ်လိန်ဖြစ်နေရလားဒါမှမဟုတ်လေဘယ်နှခုလောက်ပိုင်းဆိုင်ရှိနေရလဲပြီနော်
ပိုင်းရဟိုပါပဲဆရာကြီး second degree ကိုမှတူဟိုပါပဲရှိရ
sorry မကြားလိုက်ဘူးခင်ဗျ second degree နော်သူဒေါက်တာဂျီဂျီဘက်က line ပြတ်သွားတယ်ထင်တယ်ဆရာမိုးလုပ်ပါဦး
ဒီနေ့ဆရာမရှိရဟာ close method လုပ်လိုက်တာပါရှင်ဆရာ
ဆရာ
မိုးဆွေးနွေးပြပါဦး
ဟောရမပြောတော့ပါအကုန်ကောင်းပါတယ်အကုန်လုံးဒီဒါတွေကလူငယ်တွေကဆိုဒါတွေကနောက်ပိုင်းကျတော့ publication ကိုခက်ကဖြစ်လာကို paper လေကို paper အကြောင်းစာကိုလည်းတင်ပါ public international မြန်မာ journal စာကြွေလည်းရှိတယ် research ဟို journal လည်းရှိတယ်နောက်ပိုင်း international publication ပေါ့အဲ့ဒါလေးကိုရေးနိုင်အောင်ကြိုးစားလိုက်ရင်တော့ဒီကကောင်းပါဒီတရားတွေဟုတ်တယ်ကိုယ် original paper ဆိုဟုတ်တယ်ဒီချာလောက်တာ
ဆရာအကျဉ်းပေးချင်တာလေအဲ့ anal stenosis မရအောင်ပေါ့နော်ဒါတို့ဟိုဒါအားလုံးလည်းရွေးပါတယ်ဟိုဆရာတို့ရာဒီပိုင်းစာပတ်လေးဖြစ်တဲ့ခါကျရင်တော်တော်လေးသတိထားရတယ်ပေါ့နော် mucocutaneous junction လေးတွေကိုရအောင်ခြံတာကောင်းတယ်အဲ့ဒါလေးတခုနောက်တိတ်များတယ်တခါကျရင် daughter ပိုင်းဆိုတာမျိုးလေးရှိရခါကျရင်ဆရာတို့ရာဆရာဦးထုံးလို့ကျွန်တော်တို့အားလုံးပါပဲဆရာမိုးလို့လည်းအဲ့လိုပဲဖြစ်မှာပါအချို့အလေးကျရင်မဖြတ်တော့ဘဲနဲ့လေကျွန်တော်ဆရာတို့က ligation လုပ်တာပေါ့ underrun suture ထည့်တာပေါ့နော်အဲ့ခါကျတော့ဆရာတို့ကတကယ်တမ်းကျတော့ Doppler လေးထောက်ပြီးမှ position ကိုစမ်းပြီးမှအဲ့လိုမျိုးလုပ်တာရပေါ့နော်ဆရာတို့ရဲ့ position ကိုစမ်းပြီးတော့အဲ့ဒီဟာကိုပိုင်းစုသေးသွားအောင် ligation လုပ်တာရှိတယ်ဘယ်လိုဖြစ်ပါဒီမှာတော့ participant ကတော့နေပုံရတယ်ဒါပေမဲ့လည်းဟိုစိတ်အားမငယ်ပါနဲ့ဒါအခုဒါ this is one of the exercise for further learning as well as for your research ပေါ့ဆရာကတော့အကျဉ်းပေးနေတာပေါ့နော်ဒီ MSc ပြီးသွားပြီ doctorate တွေလည်းတက်အောင်မယ်ဘယ်လိုပဲဖြစ်ဖြစ်နေတိုင်းမှာကိုလို့သမျှ case အားလုံး document လုပ်ပြီးတော့လေဒါလေးတွေကနေပြီးတော့ research တွေ original article တွေထွက်လာအောင်လုပ်စီချင်ပါတယ်အဲ့ဒါမှဒါဟိုကိုယ့်အတွက်ကောအားလုံးတော့ကောင်းမှာပေါ့နော်လုပ်ပြီးတော့ present လုပ်တဲ့လူအားလုံးကရန်ကောင်းပါတယ်အဲ့တော့ဒီနေ့ကတော့ technical glitch တွေနည်းနည်းရှိတဲ့ခါကျတော့နည်းနည်း delay ဖြစ်သွားတာပေါ့နော် so anyway I would like to thank everybody and all the participants here as well as Thana Town ရဲ့လူတွေကို organize လုပ်ပြီး MMA ကိုကျေးဇူးတင်ပါတယ်ဆရာမိုးလေးပြောကြရှိရင်ပြောပါကျွန်တော်တို့ကတော့ပါတယ်ခင်ဗျာဆရာမိုးပြောပါဦးခင်ဗျာ
မရှိတော့ပါဆရာနောက် session ရှိပါတယ်ကျွန်တော်
Okay ပါကျေးဇူးပါပဲเนาะအဲ့ဒါ Now we are going to end this session Thank you very much ပါဟုတ်ကဲ့ပါအဲ့ဒါထွက်ပြီเนาะအားလုံးထွက်ကြပြီเนาะ
ဟုတ်ကဲ့ပါဆရာကြီးရှင်ဟုတ်
Congrats
Congratulations everybody.
မ thank you ပါ
ဝင်လို့မရလို့ဘယ်သူမှဝင်လို့မရအောင်ဒီ section ကလေပဲ့ပြဟိုဖြစ်နေတယ်တဲ့ဒီလား
technique
ပြုတ်နေတယ် plug ပြုတ်နေတယ်တဲ့အဲ့ဘယ်သူမှဝင်လို့မရဘူး complaint တက်တော့မယ်
ဟုတ်မမတီးတာလည်းဝင်မရအောင်ပြော
ဟုတ်တယ်ဘယ်သူမှဝင်မရအောင်ဘာဖြစ်လို့လဲဆိုတော့အဲ့ဒီ plug ပြုတ်နေတယ်ဆိုလားဘာဖြစ်လားအဲ့ဒါသူတို့ပြန်လုပ်တာမရဘူးတဲ့
ဟုတ်
Okay နော်
ဟုတ်ကဲ့ပါရှင်
ပါမ
ဒီပါ